Have you with us? I might chime in. Can you read that, Darcy?
Yes, I can.
Excellent. All right, so I'm having a little bit of trouble talking tonight. So welcome everybody to week 7. So Darcy, if you can't hear me, just let me know, okay? Just do like this to tell me to speak up, okay?
Okay.
All right. So how did everyone do on the assignment that we left off at? Shana?
I did okay.
Daniel? All right, Darcy?
I did okay.
Okay. I did not purposely assign you 16 and 17 while I canceled class because we're in ICD 10. There's no sense in having you watch an ICD 9 lecture and get you even more confused. The pages wouldn't have matched, and some of the answers might not have been the same. So I'd rather just cancel class. I know we're going to go into break over the next 2 weeks, but that will really give everyone time to focus on just review. Just go back and review the chapters, finish up exercises, finish up evolve exams, and stuff like that. So, has everyone found the answers on evolve? Okay. Has that worked out all right for you? Have you come to class with any questions that just didn't get answered? All right. Again, you can always email me. And if it's a really quick question, I usually will get to it that same time. But usually when I'm checking exams or anything like that, I'm doing that on the weekends. So you get quicker responses for shorter questions. So tonight we're going to focus on chapter 16 and chapter 17. 16 is all about anesthesia, and 17 is about surgery. So I probably will not try to go fast through this. As you can tell, I'm losing my voice, so we'll see how it goes. Let's start on page 490 in the textbook. And if you want to follow along in your CPT book, you can turn to page 53 in your CPT book. That is your table of contents. And you'll notice over to the left-hand side is a blank page for notes. If you turn to page 54 in your CPT book, you will notice that this is your guidelines for anesthesia. And you have some blank space on the bottom of page 55. So we'll start right here. So page 490 and 491 in your textbook, and page 54 and 55 in your CPT book. So what is an anesthesiologist? An anesthesiologist is a doctor of medicine that specializes in anesthesia. They are usually independent practices. They are not a hospital employee. So you might see Anesthesia Associates Incorporated or Pain Clinic Limited. These services will be reported separately. So sometimes you might find that you get a separate bill from the anesthesiologist on top of your hospital services. What are the uses of anesthesia? The first would be to relieve pain. And then we have it to manage unconscious patients, life functions, and resuscitation. So let's say, for example, a patient is in surgery and they suffer a cardiac arrest. That anesthesiologist is managing that patient while they're having that problem. When we administer pain relief, anesthesiologist is responsible for that. What are the different types of anesthesia? We have general, regional, local, or conscious sedation. And they also mention a few others on page 491 in your textbook. The endotracheal, the epidural. And then if you turn the page on over to 492, you'll see that we have methods of anesthesia. The administration, anesthesia, is the administration of a drug to obtain loss of sedation. Who can tell me, when would we use an endotracheal anesthesia? When would we use an endotracheal anesthesia? Usually it's for a major procedure. Yes.
Yeah.
Yep. Think of it this way, invasive, if it's an invasive procedure.
Right. I remember my girlfriend recently had to undergo some very serious operation. They had to take out one of her lungs. And she, I remember now, she had to have that done.
So an endotracheal anesthesia. Yep. And then we have local, and you'll see on page 492 in your textbook, figure 16-2, they are using an injection. And how can you tell it's local? What tells you in that picture that it's a local?
It's just a small area. They're injecting it directly to
Yes.
a specific area.
Very small space underneath the skin.
It's for minor surgeries or things like that, or sewing when they have to sew somebody up, or if they're removing something from the skin.
Yes, perfect. Did you hear that, Darcy? Excellent. Okay, and then epidural is into the epidural space, and regional would be field or nerve, which includes the spine, which includes the spinal and the epidural. A PCA is a patient-controlled analgesic. The patient here administers the drug. It's often used to control acute post-op or chronic pain. Moderate, I'm sorry?
She had that too. It was a
Yep.
little bodily or a little squeeze thing. Yes. You squeeze it in and administers morphine or whatever.
Mm-hmm.
Side effect.
Yep, pain relief. On page 493, we talk about moderate conscious sedation. This is where the patient controls his or her airway and they can respond to verbal commands. This generally will render the patient unconscious, and you'll notice a decreased level of consciousness. When we report this code, we use it with medicine codes 99143 through 99150. Pay attention to these codes because they are divided upon age. Are they greater than or less than a certain age? And the time involved. And usually it's provided by the physician who is performing the service. If you turn the page in your textbook, 494, you'll notice in the anesthesia section format, it is based on anatomic divisions. It tells you the anatomic site, and then it tells you the type. The anesthesia formula, over on page 495, 496, it's the B plus the T plus the M. All right, Shauna, what is the B? Base units, right. And Darcy, what's the T?
I'm not sure.
It's time. And then what's the
Modifying sums. M.
M is the modifying sums or the modifying units.
And then you multiply it by the conversion factor.
Yes. And we multiply that by the conversion factor. So you'll see T for time is on 498. 499 tells you about the M for the modifying unit. And then if you go over to 502, you'll see the qualifying circumstances. So to break it down a little bit further, your B is based on complexity. They use the relative value guide. And then the relative value guide, in turn, gives you the unit values that are assigned to each code. And then we pull it all together, and your anesthesia services are paid on a set amount per unit by the conversion factor. So if we have someone who is in North Carolina and they're a Medicare patient, the unit value, the base value in unit value in 2014 for a Medicare patient in North Carolina was $21.93. So we would take the time, okay, the provider records the time. Is it 15 minutes, 30 minutes, 60 minutes? Often your units are 1 unit equals 15 minutes. So 60 minutes would be 4 units. So from the beginning that the anesthesiologist manages the patient in the operating room, that's pre-op. It continues throughout the procedure, which is your intra-op, and then it ends when the patient is no longer under care of the anesthesiologist, which is your post-op. So if we have someone who started with anesthesia at 9 a.m. and the patient was discharged to the PACU or ICU at 1:30, we would have 270 minutes in the PACU, or total time for this patient, 270 minutes. So then we have the modifying unit, which is the physical condition indicated by the physical status modifier. So you see on page 503, is it? We have physical condition indicated by physical status modifier. We have P1 through P6 in your anesthesia guidelines. And these are definitely things you want to know where those are, because you may reference them quite a bit. So what is the risk factor? And keep in mind that these are not reported for Medicare. So P1 is someone who is what, Shana?
Normal.
Right. P2 is someone who is what, Darcy?
Mild systemic disease.
Yes. And 3, Daniel?
Severe systemic.
Severe systemic. And then 4 is severe systemic disease and constant threat to life. P5, not expected to survive without operation. And P6 is someone who is brain dead. So these physical status modifiers give us payment differentials based on those ratings. So another modifying unit are the qualifying circumstances. You'll see those are on page 502 on the top left, and you'll see they're in your CPT book on page 55. The qualifying circumstances are codes 99100 through 99140. Again, these are in your anesthesia guidelines. You'll also find them in the medicine section, and these are not reported for Medicare. These codes would be listed in addition to the primary anesthesia code. So, to sum up a formula, you have your B plus your T plus your M equals your total units. Then you multiply it by the conversion factor and you get your payment. So on page 504 in your textbook, you'll see they do it out for you. And down at the bottom of the page on 504, they give you some locations with conversion factors. Now, every year they change, so we would have to go looking for those conversion factors.
Now, when you first started working for a place, would they give you the conversion factor that you needed?
Yes, and usually it's in most of the software that we are using now. When we have multiple surgical procedures, once the person is anesthetized, it's the length of time, not the number of procedures. So for example, we have 2 procedures during the same session. One has a 10 base unit value. The other has a 5. What are we going to report here?
The highest one.
The highest one, right? Your HCPC modifiers. Your HCPC modifiers are added to the anesthesia codes. Now, how many are your HCPC books?
Okay. Hi, can you see Gardner?
Hi, Gardner.
Hello.
Yep, they can see us.
Yay.
Thank you.
Thank you.
Yeah,
Bye.
sorry. A little late to the party.
That's okay.
We never got the call, so wasn't sure what happened.
Okay. So, Fran, we're on page 504 in the textbook.
Okay. Let's see. Oh.
All right, so we were talking about HCPC modifiers, and I was just getting ready to ask how many people have got their HCPC books yet? No?
Nope.
Okay, so I know we're supposed to have them any time now. I don't have mine yet either, so I'll make myself a note to ask the office about HCPC books. Those are always the last ones that we get, always. All right, so some of the HCPC modifiers that are added to the anesthesia code, and I'm trying to think, where do you want to put these? Over on page 506 in your textbook. Those are the modifiers most often used with your anesthesia codes. So when you get your HCPC book, you might want to go in there and find these and tab them. At the same time, also look at the front of your CPT book and see if they are on that cover on the inside. Or some of them, or all of them.
Some HCPC's actually did a lot.
Okay,
It doesn't have the
Not the ones that I look.
okay. All right, so I do know in your HCPC book you will have more. Okay. So when you do tab them in the HCPC book, what you might want to do in your anesthesia guidelines is make a note as to what page in your HCPC book to find the modifier. Right here in the guidelines. But one of the most often used is the AD and the AA. Because you might have one anesthesiologist following multiple procedures. You also will have the QX used and the QY MAC used. That's it for anesthesia. Any questions this far? Did anyone do the end of chapter exercises? Daniel?
I did a few of them, but
Okay.
as I said, I didn't have a whole lot of time.
That's
Yeah.
fine. Okay. We'll go over some if you guys will spit out the answers. All right, Shana, what did you have on page 509 for the theory? What did you have for number 1?
Total.
Yes, total is correct. How about number 2, Darcy?
Preparing the patient to receive anesthesia.
Yep. It begins when you start to get the patient. It continues through the procedure. And then it ends when the patient is no longer under the personal care of the anesthesiologist.
Sorry.
That's fine. Fran, number 3?
I had 47.
Yes, modifier 47. Daniel, want to take a guess?
Which one was it?
Number 4.
Kind of modifier, isn't that the equivalent of patient status? Or
Yep, physical status. Yep, perfect. Shana, number 5.
Moribund.
Yes, moribund. All right, Darcy, number 6.
Systemic.
Yes, systemic. Number 7, Fran.
Excuse me, I had P6.
Yes, 6 is correct. 8, Shana.
Qualifying.
Yes, qualifying. 9, Darcy.
Anatomic.
Yes. And number 10, Fran.
Let's see, I had complex, and then I had combined total.
Yes, or total time. And then 11, Shana.
No.
No is 11. And Darcy, number 12.
Relative valve guide.
Relative value guide, yes.
Value guide.
Just keep in mind, everybody, that the answers can be found on Evolve. All right, let's go on to the practical. Shauna, what do you have for 13?
01610 P1.
01610P1. All right, what do you have for 14, Darcy?
0196 7P1 and then 01969 P1.
Yes, correct. Shana, the 15?
01965 P5.
01965P5. Daniel, did you do? Okay. 16, Fran?
I had 00215P2.
Yes. 17, Darcy?
0124214 P2 and then 99100.
Yes. 18, Shana?
01952 P1 and 99100.
Yes. 01952P1, 99100. All right. 19, Fran?
I had 01996.
Times 5.
Oh, cool. Yes, I'm sorry. You're right. Yep.
01996 times 5. And 20, Shana?
01832 P1.
01832P1. Good job.
I have a question, I'll remember, but I don't know which.
Okay?
I wrote myself a question, but I don't know what I meant.
Okay, when you figure it out, let me know. All right, let's move on to chapter 17 in the textbook.
Maybe it was for number 14.
Page 512 in the textbook. And you'll notice in your CPT guide that anesthesia is quite short. There are not many pages to it. And if you turn to your surgery guidelines on page 65, you'll notice in your CPT book, the left-hand page is a note page. You have room for notes on page 65 underneath the table of contents. And then if you turn the page to 66, you'll notice that we go right into your surgery guidelines. While these chapters may be short to go through, these again are part of the layers that we are working towards. Excuse me. So your E&M was the base layer. And then the next layer, and the next layer. So every one of these chapters builds on top of each other. All right, so the surgery section you will find is the largest CPT section in the book. The format starts with 10021 and ends with 69990. It is divided by subspecialties. And the first one is integumentary. And then we move into cardiovascular. Or I should say, we have integumentary, musculoskeletal, respiratory, cardiovascular. So from here on out, every chapter will be a subspecialty of the surgery section. What you will find throughout your surgical sections are a lot of notes. Notes and guidelines. Remember I said early on in the class to read the before, the middle, and the end. This is no different. The information will be varied and extensive. So everything is a must read. You'll notice on page 513, when we talk about manual text changes, we learned about this early on when we learned about conventions and symbols. What do those triangles mean?
It's been revised.
New or revised text symbol, yes. And then we have subsection notes. Your subsection notes apply to the entire subsection. And then we have subheading notes. They apply to your entire subheading. And your category notes, those apply to the entire category. And then we have subcategory notes. Those apply to the entire subcategory. And then you'll notice that we have additional helpful notes, which are in parentheses. Those are called parenthetical information. We then have an unlisted procedure code. Now we've learned about some of the unlisted procedure codes early on as well. Those are your 99 codes, right? These are used only when a more specific Category 1 or Category 3 code are not found. These require written reports with the submission. Each unlisted code service is paid on a case-by-case basis. Separate procedure. This will follow your code description. So turn the page, 516, down at the bottom, separate procedure. You will see separate procedure following the description of the code. It's incidental to a more major related procedure. So let's say breast biopsy. Before a radical mastectomy, same operative session would not be coded as only the procedure is performed. What would be coded? So we're doing a breast biopsy, right? And we're doing it before a radical mastectomy. It's happening during the same operative session. The breast biopsy is what would be coded. All right, I take that back. I misspoke because my brain is so foggy. Breast biopsy is incidental to the radical mastectomy. The breast biopsy is what would not be coded. It is the radical mastectomy that would be coded. So I misspoke on that one. A separate procedure is reported only when the procedure is performed and with another procedure if it's on a different site or unrelated to the major procedure. So what you want to keep in mind is that separate procedure doesn't mean that it was the only one performed. It only indicates how your code can be used. So if it's minor to the larger procedure, it probably might not be reported at all. What are some of the minor procedures? Who can tell me what would be some minor procedures?
Removing a wart from the hand, I suppose that'd be a pretty minor procedure.
Right. All right, so your minor procedures are often on a service by service basis. Often, they do not have bundle of services. Your third-party payer decides what is in a surgical bundle. And then a minor procedure for Medicare has 0 to 10-day global period. So if we're doing a minor procedure with a major procedure on a different site, would we code both of them?
It says here, yeah.
Yes.
Yeah.
Yes, correct. Keep in mind that your third-party payers turn over to 518 in the surgical package. Your third-party payers actually decide what is in a surgical bundle. So look at the surgical bundle components. What are they, Fran?
You've got pre-op visits, intraoperative visits, complications, post-op visits, any supplies they'd use, and like dressing changes or, wound check, removing catheters, staples, any of that.
Yep. And then Medicare has the correct coding initiative edit, which specifies what is in a bundle. So your reimbursement is going to vary about what you can and cannot submit. So you would have to know what the payer is looking for. This is where those verification of benefits or looking up the benefits online, however you have access to benefits, this is where you would check what those are and what is covered. So if you're doing surgery, you want to know what's in a certain package. Because what's covered in a cardiovascular surgery might be totally different than an orthopedic surgery. So some of the major guidelines of your surgical packages, usually, as Fran just talked about, the before, the during, and the after, any minor complications. Usually it's one bundle, one price. Your minor procedures may not have a bundle. And again, all of these are going to vary by payer. One of the major guideline examples, most of your payers specify 90 days after major surgery. So all of the services that are related to the surgery are in this package, including the pre-op, the intra-op, and the post-op. So if someone goes in and they have surgery and they have a visit once a week or once every 2 weeks with their physician up to the 90 days, it is supposed to be a covered service because it's part of that post-op. If you do separate reporting, this is considered unbundling. And what is unbundling, Fran?
That is fraud. It's
It is
illegal.
fraud. Yes. So what you never want to have in a bundle are your general anesthesia services because these are reported separately by the anesthesiologist. With your surgical package, the minor procedure will be pre-op and post-op services, and sometimes they can be reported separately. Again, know your guidelines. Same day may be included in performance of the procedure. They can be reported separately if it is specified by the payer. So a minor surgery example, needle biopsy in an office, that's one. You would report the procedure, which is the biopsy, and then you would report the supplies, the surgical tray. And what is on a surgical tray, Shauna? Daniel?
Surgical knives, whatever's needed for the procedure.
Materials, wipes, drugs. You would report the surgical tray with one of two codes. a 99070, which is a CPT code in your medicine section. Medicare usually bundles the surgical tray into the procedure. Or use the HCPCS code A4550. Those are not reported separately to Medicare. And that is it for surgery. Only two things I want to touch upon at the general subsection at the end. On page 521, there's two codes, 10021 and 10022. These are fine needle aspirations with or without imaging guidance. You also would have pathology codes here. 88172, 88173, and 88177. This is for an aspirate evaluation. And that's it for surgery. Any questions? Okay. Let's go ahead and do the theory and practical at the end of the chapter. What do you have for number 1, Shauna?
I have surgery.
Number 1 is surgery. Fran, what do you have for number 2?
I have no.
Correct. No. 3, Darcy?
Medical specialty. Sorry, it wasn't
Yep.
on.
4, Shauna?
Guidelines.
Yes. Daniel, you want to guess?
Triangle.
The triangles facing each other. Number 6, Fran?
Parenthetical.
7, Darcy?
Unlisted.
8, Shauna?
Special.
Special. 9, Fran?
Separate.
Yep. 10 is surgical. 11 is local. 12 is minor. What is 13, Darcy?
99070.
Yep. Shauna? 14?
I thought I didn't know it, but A4550.
A4550. And 15, Fran?
That's 99024.
Yes, 99024. All right, 16, Darcy.
Surgical.
Yep. 17, Shauna.
Commitment.
Concomitant.
Yeah.
18, Daniel, you want to guess? Fran?
I had local.
It is local. 19, Shauna.
69990.
69990. 20, Darcy.
Surgical service.
Yes. Fran, 21.
Let's see, 76942, 77002, 77012, and 77021.
Correct. Shauna, number 22.
88172, 88173, and 88177.
Correct. 88172, 88173, 88177.
But I actually got that one wrong when I did it. I put 10021 for the last one.
But you know why you got it wrong. Where'd you look up the codes?
I don't know, I did it 2 weeks ago.
Okay. Any questions with this part so far?
No.
Okay. All right. What we're going to do next is we're going to go into your CPT book. So put your textbook away for right now. I've had questions about, okay, so what do I do with my CPT book besides tab it? Well, I would hope that most of you are highlighting or underlining or bubbling stuff in your CPT book. Yes, no, maybe?
Yep.
Okay. So I'm going to just give you some suggestions. So we'll start off in the anesthesia guidelines. Now, one of the things you might want to remember is that anesthesia is usually an independent practice, not an employee. So you would write that right on the top left of the guidelines. Usually independent practice, not an employee.
That explains a separate bill you get from them when you've had surgery. You
Correct.
get that and everything else.
Yep. I can tell you the physical status modifiers are usually on the national exam. So you might want to make yourself a note that they are on the exam. You want to highlight special report is a service that is rarely provided unless you send it with a special report. Underneath separate or multiple procedures, you want to underline or highlight multiple surgical procedures. The most complex procedure is reported. Combined total. So what you're doing with these paragraphs is highlighting the words to stick out for you. You're not going through and highlighting and underlining every single line. You're pulling out the key words. So over on the left-hand column, the fourth paragraph down under anesthesia guidelines, it says to report moderate conscious sedation provided by a physician also performing the service for which conscious sedation is being provided, see codes, and then it gives you the codes. You can just circle that whole paragraph or put a big red asterisk next to it. Just something that draws your attention to it. Underneath qualifying circumstances, over on the page 50, what is it?
Page
55. Highlight the last paragraph, line on the paragraph that says, these procedures would not be reported alone, but would be reported as additional procedure numbers qualifying an anesthesia procedure or service. Okay, turn the page. Right next to anesthesia. How is anesthesia divided? It's divided by anatomic site. Right next to it. Anatomic site. Next to code 00126. It's a tympanotomy. What else is it also called? What else is it called? It's also known. Go ahead.
Is it myringotomy?
It's
Sorry.
also known as a myringotomy. So you want to write beside it, myringotomy. Myringotomy.
No, beside what?
Tympanotomy. Okay, turn the page to lower abdomen. You have a parenthetical note about midway down under lower abdomen. It says, do not report 00834 in conjunction with 99100. Highlight it.
Where?
Underneath lower abdomen. About midway down, you have a parenthetical note, do not report 00834 in conjunction with 99100. Right next to code 00836, you might want to put yourself a note that says, watch age on codes. Next to code 00836, watch age on codes. Because if you look right in 00836, it gives you what? Ages, yes. Over on the next page, underneath perineum, put brackets around code 00910 and 00918.
Actually, the girl I work with had the bad experience I had the first time we did drove together in a place. It was not a good experience. Can I bring her one time? Oh, yeah. I know she doesn't think that she's got that.
Next to the bracket, put labor intense, because these are labor intensive codes. Turn the page over to lower leg. What you're looking for here, and I don't know if any of you have started to do this, but we call it bubbling. So if you look at codes, okay, when I talk about bubbling, you want to bubble like codes that all have to do with the same thing. So these two codes have to do with anesthesia for closed procedures on lower leg, ankle, foot, anesthesia for arthroscopic procedures of ankle and or foot. So you can bubble those. And you can highlight closed procedure on one and arthroscopic procedure on the next one. Now, if you don't want to do a bubble, you can just bracket them. Again, the idea is to draw them to your eye. So the next set, you would bubble or bracket 01470, 01472, and 01474. Okay? The first one is the major one. The second two go with that one. So if you were to read 01470, are those other two related to it? Yes, they are. Then the next four codes, 01480 through 01486, bracket or bubble. You can highlight the type of procedure. Is it open? Is it closed? Is it arthroscopic? Is it on the lower leg? Is it on the ankle, foot? These are things I would highlight or underline to draw them to your attention. Over underneath burn, excisions, or debridement. What I would highlight or underline here is the percentage. In code 01951, you have less than 4% total body surface area. In the next code, you have between 4 and 9% of total body surface area. And the next code is each additional 9%, and it's an add-on code. So you might put a bracket around these, and when you do, put a note that says, watch the add-on codes. When you see a plus sign, what is that?
It's
an
an
add-on
add-on.
code. Yep. If you go underneath obstetric, excuse me, highlight vaginal delivery, cesarean delivery, hysterectomy, cesarean hysterectomy, incomplete or missed, induced.
Sorry.
Bless you. Okay, does that help everyone?
It does.
Okay. So that's really what you want to try and do throughout your CPT book. I mean, if you don't, you don't. It's totally up to you. But it's going to help bring those descriptions to your eyes quicker. So that when you're scanning during your homework, during your exam, you will be able to pick those up quicker.
I just wish there were more note pages where you could write things,
Yeah.
in there.
So as we get into the different sections, you'll notice you want to highlight or underline ages, percentages, body area, the anatomic site, the type of procedure maybe being performed, biopsy, lesion, number of lesions, centimeters. Again, the bubbling or the bracketing will make a difference. Reading your guidelines, your notes before, during, and after. All of that is going to make a difference. All right, I'd like to go into the workbook and do some of the reports in the integumentary section. Let's do report number 6 on page 111 in your workbook. Report number 6, you will find it in the back of the book on page 212. And so we have a pre-op and a post-op here. What are we going to look at for procedure? We have a pre and a post. How are we going to diagnose it? Based on what? Post-operative diagnosis. So it would be a scar of the right parietal region. And what is the surgical procedure that was performed? Okay, excision, scar of scalp. So take a few minutes, take and read it, and let's look up the procedure code. All right, so let's talk it out loud. What are we going to start with? What was the procedure?
Excision.
It was an excision. What was it an excision of?
Scar.
Well, yes. What is a scar considered? Because if you look in the procedure, it tells us that the lesion was anesthetized. So excision of a lesion. And the lesion is part of the skin. So excision, lesion, skin. And was it benign or malignant? Benign. So excision, lesion, skin, benign. So it gives us half a dozen codes to look up. And how big was it? 3 by 1 centimeter. So would we say 3 centimeters? Okay, Darcy, what did you get?
11423.
Okay, what did you get, Fran?
I got 11403.
Okay, what did you get? Come up with, Daniel?
11403.
And Shauna. Okay, so this is a perfect example of number 1, highlighting what type of lesion it is. So is it benign or is it malignant? And then the anatomic site, so scalp, neck, hands, feet, and genitalia. So 11423 is the correct answer because it's the excised diameter of 2.1 to 3.0 centimeters. Daniel, what did you choose?
11403.
Okay, but if you look at 11400, it is for trunk, arms, or legs. So remember we were talking earlier, your category, your subcategories. So you've got to go back to the top. You have to see where are your anatomic site. What is your anatomic site? And then drill down to the subcategories. Am I in the right category? And then am I in the right centimeters? Make sense? So Daniel, it's an honest mistake. It happens to every one of us. because we're quick. We want that answer. We want that instant gratification. Okay? Does that help? Shauna? You still look.
I didn't look it up that way. I started with scalp.
Okay,
That's why.
that's fine.
Okay.
There's more than one way to look them up. It's just getting to the right answer. But if you start by the procedure, because we're in the CPT book, you start by the procedure first. But the fact that you went to scalp doesn't mean you did it wrong. All right, what's the next one? Number 48, report number 8, over on page 213. Okay, so this is a pre and post. What is the post-operative diagnosis? Multiple sinus tracts. What is the surgical procedure?
Roofing with the sinus tracts.
Yep, so it's a full debridement. So what is the procedure? Debridement. All right, Fran, what do you think?
I got 11042.
Okay. Darcy? Okay, turn it on, Darcy.
I keep doing that. I didn't get anything yet. I'm still
Okay.
looking.
Where are you looking?
Under sinus endoscopy.
Okay. What about debridement?
Well, I went to debridement in the back of the book, and it brought me to the end, the sinus.
Okay, so let's do this together.
Okay.
Debridement. On page 823. Okay, and then we're doing skin and subcutaneous tissue because if you look at your report, it says partial unroofing of sinus tracts. This is a full thickness debridement. So
Okay.
when you see that, you're going to be talking about tissue because tissue is part of the sinus tracts. So skin, subcutaneous tissue. We know it's not infected or not necrotized. So we're going to go to code 11042 through 11047. Now, how many of you thought sinus tract was part of your nose?
I did until I read more.
Okay, well, sinus tract has to do with the buttocks.
Well, I saw that, but that kind of confused me, I guess.
Yeah. So now, if you look at 11042 through 11047, what code or codes would be the appropriate codes? And how many centimeters did we end up having? I think the total was at 15 times 8 centimeters in their total dimensions. So, Daniel, what did you come up with?
Honestly, I hadn't come up with an answer yet.
Okay. Shanna?
I was totally wrong.
Okay. Darcy?
I still don't have one.
Okay. So,
I did answer before.
okay. So 11042 is the first code. And then if you read on, it says first 20 square centimeters or less. Well, we had 15 times 8 centimeters in the total dimension, so we had more than just 20 square centimeters.
125.
So we had to use the add-on code 11045. Did the light bulb go on, Fran?
Yeah, as you said that, I was like, oh yeah, that's right, because it's.
I saw you shaking your head, yep. And then you'll see down below in a parenthetical note that it says use 11045 in conjunction with 11042. Okay. And what is our diagnosis here? What are we looking for a diagnosis? You don't have to look it up, just tell me.
Granuloma.
The granuloma, yes. What type? A pyogenic. And a pyogenic of the skin. All right. So that just leaves you one more to do for homework on that page. Let's go into the musculoskeletal system and do some reports there. I know you love me. Page 120 in the workbook. And number 60 is report number 10. Page 214 in the back of the workbook. The pre and post-op is the same. What was the procedure performed, Daniel?
Placement of halo crown invest.
Placement of a halo crown, right. So what do you think we're going to look up? Halo. So go to halo. And what type of halo is it? Where is it being placed? On the head. And that would be your cranial. If you look at the procedure, it tells you the hair was shaved behind both ears. There was a sterile prep done along the forehead region and the region behind both ears. The halo crown was then positioned and stabilized with 3 positioners anteriorly and 2 laterally. So it is a cranial halo. And this is where sticky notes or pens or markers or pencils come in handy, because as you're going between pages, you don't want to be flipping back and forth and losing your pages. So you stick something in between so you don't lose them. Don't have to look them up again. Shauna, what did you come up with?
20661.
Daniel?
20661.
Fran?
I get the same.
Darcy?
I got the same.
Excellent. Okay. How about 64, report 16? Report 16 is on page 218. What is the procedure that's going to be coded? procedure would be an arthroscopy. What type of arthroscopy? It would be surgical. What anatomic site? It would be knee. All right, Daniel, where are you at? Where are you at in the book?
Well, I started at 29866, which is the base operation for it.
Perfect.
And from there, I'm trying to find and see if there's anything that's more specific than that.
Yes, correct. All right, Shanna.
I'm looking at with meniscus repair.
Okay, which is what number?
2982.
Perfect. Close. Fran.
I'm over in the arthroscopy of the knee, and I have 29880.
Okay, close. Darcy.
29883.
Oh, you're also close.
Is it
Okay.
291?
It's 29881.
Ah!
Because if you look in the postoperative diagnosis, it talks to you about the chondromalacia and the medial femoral condyle. So 29881 encompasses the meniscectomy, medial or lateral, including the shaving, the debridement, the chondroplasty, blah, blah, blah. Good work. Excellent. Okay. About 66, report number 18. The postoperative and preoperative are the same. Comminuted fracture, right olecranon process of the ulna. Open reduction, internal fixation, right olecranon fracture. What are we going to look up? First thing, what is it?
Fracture.
Right, it's a fracture. Fracture of what? The ulna. What did you get, Fran?
Two, 4, 6, 8, 5.
Darcy?
I got the same thing.
Daniel?
Mm-hmm.
Summer? All right, so far so good? You feeling comfortable with the next assignment? Okay.
As long as I don't do what I almost did this time.
Yeah.
I found the answer, but started thinking to myself, well, maybe there's another answer. Maybe there's a nope. Just
Yeah.
probably right.
So what I'd like to do right now is let's start back on page 107 in your workbook. And let's go through each one and pick out the main term that you're going to choose to look up the codes. Do you think that will be helpful? Yes, no, maybe?
Yes.
Very.
Sure.
Can we just
All right.
take a break for a second? I just need to use the restroom.
Absolutely. Go right ahead. All right, so page 107 in your workbook, we're just going to go through each exercise and pick out the main terminology that we would, number one, look up the procedure code, and number two, the diagnosis code. Do you want to do both or just one? We'll do both. All right, so number 23. I'm not going to read these out loud. Just spit it out. What do you think we're going to start with in 23?
Repair the wound in her arm.
Right, repair of the wound. And then the location is the arm. Now, you could probably put right or left, but you won't need to on all of them, okay? Sometimes you might need a modifier, sometimes not. It's not always clear cut. So, go ahead.
The 2.6 centimeters might be important.
Yes, the 2.6 centimeters are very important. But also the fact that it's an intermediate repair. Also, the diagnosis would be what? The diagnosis is for a wound. What kind of wound? An open one. Where is it located? So ask yourself these questions as you're looking at each of these exercises, okay? And I usually tell you just the even numbers, right? Okay, so on 24, this one would be a simple wound repair. Don't forget to add the surgical tray. The surgical tray is also going to be coded here. Your diagnosis is on a wound also. What type? Is it open or closed? And where is it located? 26. All right. Mr. Jones visiting Dr. Green after a major surgery. What kind of code is that? Right, post-op surgery or special surgical. Basically, it's a post-op visit because it falls within that 90 days. And what are we coding for a diagnosis?
Post-operative?
Yeah, or actually exam follow-up. 28 is going to be debridement. Debridement of what? Of the muscle. And why? Well, that's where the diagnosis comes in. The diagnosis is going to be for diabetes. So diabetic type 2 with foot ulcer. You're actually going to have two codes there. You're going to have the one for the diabetes and then one for the ulcer of the lower limb. All right, 30. 30 is excision. Excision of what? A cyst. Yep, pilonidal cyst. And our diagnosis is going to be the cyst, the pilonidal, with an abscess. 32, debridement of the nails. The diagnosis is the onychomycosis. 34. Shauna, what are we going to look up for a procedure?
Excision of a lip lesion
Yep. And,
and 2 malignant lesions of the chest.
yep. Are you able to combine those two? No, you can't, because one is the lip and one is the chest.
They're 2 different body areas.
2 different body areas. And the diagnoses would be for skin of the lip, skin of the trunk. And they are both neoplasms and they are malignant. Okay, 36. Darcy, what do you think? 36. What's the procedure there?
Destruction
Yep, destruction of what?
of a lesion.
Yes. And a lesion is part of the skin. And then we ask, is it malignant or benign? And our diagnosis would be neoplasm of the skin eyelid, malignant. 38. Shauna, what's our procedure there?
Electrosurgical destruction.
Destruction, yep. And destruction of what?
Lesion.
Yes. All right. And the diagnosis, Daniel, what would we look up?
For the lesion of the neck.
Yep. It also ends up being a neoplasm too. So, all right, 40. Fran, what are we looking for a procedure? We're actually going to have 4 procedures here.
Let's see, laser destruction.
What type of, yes, laser destruction, but the main term there being destruction.
Yep.
Okay, and then we have multiple malignant lesions. We are not going to combine them. We actually have 4 different CPT codes. Okay? And for diagnoses, you will end up with 4. Forty-two is a blepharoplasty. 44. What is 44, Daniel?
Micrographic surgery.
Yes, a Mohs micrographic surgery. Perfect. We already did some of their reports. And we move on to page 115 in the workbook, chapter 19. All right, number 22. The patient is returning to the physician's office 2 weeks post-surgery for an application of a new leg cast. The patient required surgery due to a traumatic fracture of the lower leg. What's he having done there?
New cast.
Cast. And it's going to be a long leg cast. Because it says right there, new long leg cast. That is the procedure. Okay, number 24. What are we going to do there? Fran, what's the procedure?
Arthroscopy, diagnostic.
Yes. Yep. And usually when they do them like that, it would be surgical, right? Okay? So arthroscopy, surgical. All right. 26. closed treatment of a pelvic rim fracture without manipulation. Darcy, what's procedure?
Fracture.
Yep. Okay. Fracture of the pelvic ring, and it is a closed treatment. Keep in mind, closed treatment, open treatment. All right, 28, Shana.
Open treatment. Of a hip dislocation.
Yep, so turn it around. Dislocation first, open treatment is last. So dislocation of what? Dislocation of the hip. What type of treatment? Open. All right, 30, Daniel.
Patellar dislocation, closed treatment.
Yep, dislocation. All right, 32, Fran.
Dislocation, closed treatment.
Yep. Dislocation of what?
Tarsal bone.
You got
Closed
it.
tarsal.
34, Darcy.
Fracture of the Lefort one maxillary.
Yep. So fracture of the maxilla. And 36, Shana.
Removal of screws.
Perfect. Removal of fixation device. And 38, Daniel.
Graft, cartilage, costochondral.
Got it. Graft, cartilage. You guys are awesome. All right. Fran, 40.
Aspiration of
Yes. Of the joint. Yep.
Yep.
42, Darcy.
I did it again. A removal of the short arm cast.
Close but no cigar, and I'm not going to answer this one. I'm going to let you guys do the homework, and then you'll know why. It's because it's in the reading, okay? 44, Shana.
Wait, I'm check off 42.
Oh, I'm not giving you the answer to 42.
I know, I was reading it. Application.
Of what?
Body cast.
So it's going to be a cast or body cast of what part of the body? Upper body only. All right, 46, Daniel.
Application, splint, short.
Yes. 48, Fran.
Application of a splint, long arm.
Okay. So when you think of application, what does that actually mean?
They're putting it on.
Right. But we can't code the word application. So what's actually being done is the splint. Okay? Just keep that in mind. 50, surgical arthroscopy of the temporomandibular joint. What is being done here, Shana?
Arthroscopy.
Yes, arthroscopy. 52, Daniel.
Surgical arthroscopy of the elbow.
Yep. 54, Fran.
Arthroscopy, surgical, of the knee, the meniscus.
Okay, 56, Darcy. Read it carefully.
fasciotomy of the plantar.
Perfect. Perfect. And 58, Shana?
Arthrocentesis.
Yes, of what?
Cervical joint.
Of the ganglion cyst. Perfect. All right. I hate to do this to you guys, but I really feel miserable. So we're going to call it a night. We have gone through 16 and 17. Your assignments for when you return. '18 and 19. That will be, I believe, integumentary and musculoskeletal. We just went over the reports and some of the homework to help you get through the homework. Was that helpful?
Yes. When is our next class going to be? It's not for a couple weeks, is it?
Right,
Or
because
is
we
it?
have the 2 holidays. So we come back
January.
What's the first Thursday in January? So January 7th. Okay. So, what I was saying to the class when we started, this gives you time to go back and review any chapters that you felt you had a hard time with. It allows you to do the assignments if you didn't finish them. It also, I would like to see everyone caught up with your Evolve exams. If you have not done them, please finish them. If there are any that you want to retake, let me know. You can still go ahead and email me any questions that you have, and I will get back to answering all of you as soon as possible. But thank you very much for your time tonight. I'm sorry not able to speak as much. For some of you, you might like that. But thank you very much, and I hope that you all have a nice holiday season.
I hope you feel better, and hopefully you have a good holiday too.
Thank you very much. Bye, everybody.
Bye.